On behalf of the Australian Institute of Health Innovation and the Rare Disease Awareness, Education, Support and Training RArEST Project, I would like to extend my very warm welcome to everyone attending today. Thank you so much for giving up your time to come along and share your expertise and knowledge and ideas, and to do some work with us and hopefully to have some fun as well. So often we learn best through experience and play, and there will be both elements of those in this workshop. So hopefully you have fun as well as doing some good work. I would particularly like to thank and acknowledge the expertise of people with lived experience of rare disease and rare disease organisation leaders. It's always amazing and very humbling for us to see the incredible changes that you have already made to improve care for people living with rare disease. So we'll go to acknowledgement of country. We acknowledge the traditional custodians of the land on which Macquarie University stands, the Wallumattagal clan of the Darug Nation, whose cultures and customs have nurtured and continue to nurture this land since time immemorial. We pay our respects to the elders, past and present, and we acknowledge the traditional custodians of the various lands from which you all come today, and the Aboriginal and Torres Strait Islander people participating in this event. If you have the chance after the workshop to walk around the campus, it is a beautiful campus. There's a lake, there's a creek, there's lots of open spaces, and there are some very important sites on this land. So we have a loose agenda, but right now I'd like to introduce some key people who were involved in developing this workshop. So Christina Rogers, who's the RArEST Project Officer, has led the organisation of this. Professor Jeffrey Braithwaite, who is the founding director of the Australian Institute of Health Innovation, who will lead you through the workshop. And Jeffrey has run these workshops for many different groups, including Harvard, the UK and Canada and many other countries. Clare Stuart, thank you for being here, Clare. And Clare's going to give us a little talk later. Nat is the manager for the RArEST Project, and thank you for being here, Nat, and helping with the evaluation and the note-taking. And the AIHI support team, so Nehal Singh, Kaylin Smith, and Shalini Wijakuli Surya. We're going to keep the presentations to a minimum because we really want this to be an interactive workshop, and we will be challenging you. You will be moving around the room, so just be prepared for that. All right, so a little bit about the RArEST Project. So it's the Rare Disease Awareness, Education, Support and Training Project. It's a collaboration between Rare Voices Australia, University of New South Wales, University of Western Australia and Macquarie University. And we have three streams. So stream 1, support for individuals, including mental health and wellbeing resources. Stream 2, health professional education, support and training. And Emma Palmer, who's just there, has been doing amazing work leading that stream, to the point we actually have launched the National Recommendations for Rare Disease Care on Rare Disease Day on the 29th of February. So that's an amazing achievement. We're looking at adopting a co-design approach to awareness and education for systemic improvement in rare disease care and support. Okay. So I'll now hand over to Jeffrey. Thank you, Jeffrey.
So thanks very much, Yvonne. So I'm Jeffrey. I'm the director of the Institute, which is a big group of health systems researchers. And what we're interested in the Institute is doing research to make for a better healthcare system. And we do different kinds of research to underpin better care. So we're not on the front lines delivering care, where those of us who were clinicians aren't really clinicians anymore. We're sort of where medicine, nursing and allied health professionals meets all the other different kinds of researchers you need to understand, do good research, and then improve the health system. And that's what those words are trying to say. So unlike most medical research groups, we don't have a lab. Our laboratory, if you want to call the health system a laboratory, is the health system. And so we're in the same, we have the same perspective as you do. Everybody in this room experiences the health system in a different way and would like for the care to be continuously improved over time. So we have better care for our loved ones, for people we know, for patients we don't even know, but who we'd like to have a better health system for. So that's the space we occupy. How do we have a better health system? And our bit of the jigsaw puzzle is, how do we have a better health system by doing research to underpin good decision making, whether that's research in policy or in leadership and management of the system or clinical practice or patients being involved in research so we have good co-design. So that's our thing. I'll just talk a little bit more about the Institute, just so you know where we're coming from. And then we'll talk a little bit more about rare diseases, but then we'll do a simulation. And what we're going to essentially do, it's not like a detective novel where you have to wait till the last page. So you have to wait till 2 o'clock to find out the results. What we're going to do is riff off your experience, your perspective on healthcare, on the health system, wherever you come from, whatever that experience has been. And we're going to put you in a different role from the role you normally occupy. The stance that you normally have on the health system, we're going to put you in a different role, and then we're going to work through some problems that we encounter when we're navigating this complex system, this complex health system. And then we're going to see what we've learned from that. And Yvonne's right, I've done this with different groups, and people often find this is a very useful experience. If you like to make it simple, we're going to invite you to stand in the shoes of other people in the health system. And everyone's going to be looking at healthcare from a different standpoint. And we're going to see what we learn from that mass transfer of empathy to another standpoint. So we call this the simulation game. So Institute, we've got 7 research centres. And if you're not a researcher and this isn't of interest, you can sort of gloss over this. But we've got 7 research centres, all doing stuff. And it's a bit like Rubik's Cube, you know, the Matrix movie. It's a bit like, what are the different types of research we can do to help underpin a better health system? So these are the names of the centres, and these are some of the people in the centres who are the co-directors running our institute. We've got about 300 people all associated with this research. If your work, by the way, outside of what you're here for, maps to any of those centres, just get in touch with us. We're always looking for people to join us in our research endeavours. So one of the things we like to think is it's easy to conceptualise the health system, to think about the health system as a kind of linear system. Kind of like, if I do X, I will get Y. And anybody who's navigated the system with a loved one with a rare disease knows immediately that's not the way the system works. If I get a diagnosis, I'll be able to know what to do next. Even getting a diagnosis is just not easy. And so what we like to think about is many people conceptualize healthcare as a bit like an organization chart. So there's a CEO in some organization, a hospital or something, and then there's all these layers, and then at this bottom level, there's all the clinicians interfacing with all the patients and the relatives. And so many of us at various times have this model of the health system in our head, but actually healthcare doesn't look like that. It looks like this. And if you've got someone in your family, or you care for someone with a rare disease, you know that straight away. So navigating that is a much different proposition to thinking about healthcare like that. And so we think this nicely captures what many people experience as they go through the system, even just getting ordinary care, let alone trying to get care for a rare disease. By the way, that's not the whole health system in that swirly diagram. That's only a depiction of an emergency department. I don't have a big enough slide to show all the swirly navigating things you have to do to navigate through the health system to get care. So that's the paradigm in the Institute that we play with. And that's the paradigm I just want to have sticking in your mind when we turn shortly to this simulation game and we simulate the health system. So I got more slides and you can have a copy of these slides, but we don't want this to be a lecture. So you can think about different examples from healthcare about what makes it complex. So you can have simple things like you get a test and you get a single data point or a couple of data points, and that's relatively simple. Somebody, the doctor, can know what that number means. And patients who've been involved in the system for a while, they know what that number means. And if it goes up or down, you know, that triggers some sort of, well, we better think about that and do something differently. That's relatively simple, getting a number in a test. Complicated is, okay, the clinician has this patient with all their complexity in front of them, and they need to know their vital signs and how they react to drugs and what's in their medical record and what their test results from the past are. So that's complicated. Complex is when you then put together a number of different stakeholders all trying to collaborate over the care of an individual or a group. In the operating theatre, for example, or in the emergency department, or in a ward, or in a general practice, a busy general practice. Chaotic is not what we want. That's when things get out of control. So you can think of a bus crash, there's 50 patients all descend simultaneously on a hospital, or worse still, there isn't a hospital, so the GPs have to rush out of the general practice and do something to attend to that. So that's chaotic for a while until we get the system back under control. And one of the things when we do all of our research in healthcare, Yvonne and I and Kaylin and, you know, all the people in the Institute dotted around here in the audience, we're mostly in the complex arena. We're mostly here. Most of the time, healthcare looks like this. Certainly, it doesn't most of the time look like this. That's what the glossy brochure put out by the local health district or the PHN looks like. But that's not a very good representation of your lived experience of working through the system to try and make it all work for you. Agreed? I'm just telling you what you already know with some fancy academic diagrams. So, what we want to do, if that's a given, is take a holistic approach. And who better to explain that than Yvonne Zurynski?
So when we talk about the health system, it's actually a number of different systems that interact with each other. And those different systems include, you know, there's a socio and technical system, there's an economic system at play. So it's not as simple as we might conceptualize in one of those charts. And of course, the system sits within society and a context. And the geographical and population context. So, you know, it needs to consider what the consumers or patients need and their carers. It considers the economy, the political forces. There are workforce forces. There's enormous workforce forces at the moment because there's a massive shortage of healthcare workers. The media has a role to play in all of this as well. And technology can be good and it can be bad. So just keep that in mind. All of those things interplay within the system. So it's not just one system, it's a number of systems working together. And if you look at the Australian health system, and I won't really go through this, but there are multiple layers and multiple funding streams, and a lot of it is actually siloed and it's really difficult to unravel. So in addition to all that, you know, complexity that Jeffrey talked about, the actual structure of our system and the governance of our system adds additional layers of complexity. In addition to that, we have a federated system. So if you happen to live on a border and you need to access care in the next state, that adds additional complexity because there's no sharing of records, they work differently, all kinds of things that some of you may have experienced. And then on top of that, there's the complexity that people living with rare disease experience. And what people living with rare disease have told us is that they have inequitable access to healthcare and limited referral pathways and lack care coordination, which makes navigation really difficult. So you've got the complexity of the system and the complexity of the person, their condition or their conditions, and their family complexities as well. Specialised clinics, health services, medicines and therapies are often not available or not easily accessible. Diagnosis is often delayed and there are misdiagnoses, often due to lack of knowledge, training and experience. But sometimes, you know, health professionals simply don't believe people who present with strange clusters of symptoms, or they've never seen such a cluster, so it's really difficult to diagnose. And data capture, we don't do data capture very well for people with rare diseases, so there are limited systems or registries, and we really need to improve that in that area. So why do we worry about rare diseases? All health systems really need to worry about rare diseases because there are lots and lots of people who live with a rare disease. There are about 7,000 known rare diseases, and about 80% of them are genetic in origin, and it's estimated that approximately 8% of Australians have a rare disease. That's on par with diabetes. You hear a lot about diabetes, you don't hear a lot about rare disease. So today we're looking at improving care for people living with rare disease, and particularly looking at the systems that could potentially help with transition from paediatric to adult care. There's a gap. Those two systems are quite separate. And there's a different way of working in paediatrics. But at 18, young people do need to transition to adult care. And often that is a very fraught journey. It's very difficult to navigate. So today, I think we're going to be exploring this issue and looking for some solutions. So a successful transition involves a good introduction to the concept, preparation early. They need to be prepared. It's more than a transfer. There needs to be coordination of care, and the adult physicians and paediatric physicians need to work together. This is just something that we've been working on, and Lauren McKnight put this slide together. Here are some quotes. So this multi-stakeholder approach is the philosophy that multiple stakeholders not only have an interest but a responsibility to be a part of this work. So wherever you are in the system, whether you're a family, whether you're a rare disease organisation, whether you're in government, industry, state and federal health, health management, you know, researchers and academics, we all have a responsibility for this area.
Thanks for inviting me to speak. It's always a big responsibility to contribute some personal perspectives, but be seen as presenting on behalf of a very diverse and large community. I do wear many hats, and we've put the Mito Foundation logo here today, but I'll tell you about why that hat is probably not as relevant to today's challenge around transition. So I do have the privilege of running policy and advocacy for Mito Foundation, which I'm fairly confident in saying is probably the largest rare disease organisation in Australia. Rare Voices is almost catching up. But that comes with a huge privilege, and I don't have a lived experience of mitochondrial disease, with the exception of the people that I've met through my current role. Of mitochondrial disease, but I do have a lived experience of rare disease, and I continue to use the privilege of this role to try and make change that goes beyond Mito. But there are around 5,000 Australians living with Mito because there are about 300 different conditions that fall under that umbrella. So when we talk about the rarity of rare conditions, but when you add them up, Mito is a great example. We're about to publish our first ever health economic study into mitochondrial disease, and with some amazing magic that health economists do, we've managed to calculate that the cost of Mito in Australia is approximately $1 billion a year. So it's not an insignificant challenge. And it would be interesting to extrapolate those numbers given the diversity of Mito. I'd argue that'd be a fairly simple exercise to go. Probably, quite a few billion rare diseases would cost us each year in Australia from an economic impact. The diagnostic odyssey certainly affects the Mito community. There's some data that suggests that the majority of adults with Mito will see about 5 specialists and take about 10 years to get to the point from first kind of obvious Mito symptoms through to a diagnosis. And improving healthcare is absolutely the #1 priority that the Mito community shares with Mito Foundation. They have particular trouble accessing coordinated care, although we have great published patient care standards now that say everyone should have a management plan, should have professional allied health advice on exercise and diet. Our surveys with our community suggest only about 25% have an ongoing management plan. Only about 30% have an emergency management plan, which is incredibly important with Mito. Only about 50% have ever received any professional advice around exercise. Only about 35% have received professional advice about diet, despite knowing that they're some of the most effective ways of improving their health and their lives. So we've got an incredible way to go, despite having a fairly well-resourced organisation trying to make change. But transition is actually, unfortunately, due to the natural history of Mito, often not major on our radar. Most children with Mito have a life expectancy that averages at about 6 years. So that includes babies that die very early in life and people that are fortunate to live to about 10. Adults with Mito will present to the adult health system. So I'm glad that I could make it to this one of your simulation workshops, but for Mito Foundation, transition is probably one of those health issues that we kind of don't need to worry about. We look forward to a day that we will need to worry about it. So instead, I just wanted to speak for 1 more minute about my own lived experience of rare disease, where transition was much more important. So the reason I got into this sector is that about 2 years after I was born, my little sister was born with a genetic condition called tuberous sclerosis. For her, and her name was Lizzie, that meant that she lived with very hard to control seizures, a profound intellectual disability, and a very complex part of tuberous sclerosis called polycystic kidney disease. That eventually led to her death about 14 years ago. I had to do the maths. But during the 26 years of her life, as her sibling, I travelled that road through the healthcare system along with her, and particularly my mum. We're a fairly well gender divided family. My father and my 3 brothers probably couldn't give you as much information as mum and I could. And certainly Lizzie did experience transition. Her paediatric healthcare team was amazing, still somewhat disjointed in our children's hospitals, but did sort of work mostly together and focused on the right things. Coordination of all of them still fell to my mother, who at the same time was running the rare disease organisation. So she's looking after her own health, her 5 children, her child with a complex disabilities health, and trying to help people all around Australia and New Zealand. And she had an almost full-time job. So she was incredible, but really not the person that had the knowledge or time to do care coordination. And today we're talking about healthcare, but it's important to remember, as Yvonne's first slide showed, that we also interact with disability and with education. And then you can sort of go, well, where does mental health fit? Because that's a bit across everything. Lizzie did transition to adult healthcare services, and generally her individual specialists did a great job. And this was back in the 1990s or early 2000s. They did a great job of finding another specialist, and that handovers generally worked quite well. I think with transition, I always want to make a point that the process is important, but the destination is, insert expletive here. I usually use the F word. I think I used that with Karen yesterday. So it's great to talk about transition, but we have to acknowledge that our adult healthcare system and the way that it's designed today does a really poor job on the whole of providing care to people that have multi-system and let alone needs outside the health system. So I love talking about transition and how we can do that, but we do need to acknowledge that the adult system is nowhere near as well equipped as our paediatric systems are. As a couple of examples of I'll give 2, and I'm going to try not to cry. So particularly, and this relates to my sister's intellectual disability, the adults involved in one of her ICU stays after a status epilepticus kind of situation. She was in ICU, I think, for about a week, and my parents and I had been rotating through to be there with her. She was restrained because she was coming in and out of consciousness. I'm not a doctor, so I'll use the wrong words. One nurse came on shift, asked my mother why this patient was restrained. My mother explained, and then my mother went home for a quick sleep because Lizzie had been quite stable, I suppose. Got a call 45 minutes later because that nurse had removed the restraints and my sister had extubated herself. And we weren't entirely sure whether her lungs were going to work, but they did. And that was just a classic example of where the role of a parent in having something to add to the healthcare team was overridden by a very well-intentioned nurse who'd probably been trained in not to use restraint unless it was perfectly necessary. But it was entirely unnecessary medical trauma for my sister to go through, and fortunately she survived that. Improving care is absolutely a passion, and the consistent thing that I have experienced in what I've turned into a job is that we have amazing clinicians. They know their stuff, they're motivated, they're passionate, but our systems don't support them to create change and create sustainable change. We dealt for a long time in tuberous sclerosis with what we referred to as clinics by stealth, that these fantastic clinicians, mostly paediatric neurologists and clinical geneticists, would create multidisciplinary teams. But a new hospital policy would come in to say no more services. And they're like, well, we're not really a service. Well, no, we have no care coordination time. We have no nurses to support your multidisciplinary team. And that service would have to go under the radar again. And we'd have to quietly tell patients to try and get a referral to genetics. It's despite them doing great work. So we have a long way to go, and I look forward to being part of the solution of how we can support amazing people with great intentions to create those sustainable changes that we need. Thank you.
Thank you, Claire, for sharing that. That's really amazing and sobering story. And I think, you know, you're talking about the 1990s, but it probably still happens that way. All right, so we're going to get you to do a little bit of work now.
Now what we're going to do is we just want you to bear in mind what we said. We didn't want to overstimulate you with lots and lots of like research results or frameworks or our perspectives, because what we want to do is bounce off the experience in the room and create a simulation of the health system, which you know and love, where various degrees of love, as you interface with it. So what we would like to do is use the tables and create some groups. So just hold on for a second. So everyone's included. I think the people who are going to stand out of this are the organising team, Christina, Nihal, and Yvonne. Kaylin, are you in or out? In, okay, you're in a group, okay. And you're going to be assigned to a perspective from which you'll have to solve a problem and look at the health system through this perspective. So there's a bit of role playing, and can I just encourage you to embrace the role that you are arbitrarily assigned to? Just so you see the world from that standpoint, and you also see other people with a slight level of discomfort too, because they'll be in a role that they're not familiar with as well. So here's the problem. It's the 21st of March, 2024. This morning, Prime Minister Albanese announced that our health system is too fragmented and inequitable for people living with rare disease. Thank you, Prime Minister Albanese. More than ever before, he goes on to say, a collaborative, integrated, joined up system providing social justice and compassionate care is needed. What a far-thinking Prime Minister to say such words. I know that the best and most experienced systems thinkers are at the simulation workshop at Macquarie University today, and they can help. So I'd like to ask that group, how would you improve care integration and transitions for young people living with rare conditions? So this is a request from no less than the Prime Minister of Australia to you. So these are the stakeholders. Now you're going to be arbitrarily assigned to one of those stakeholder groups. Now we have to debrief you because you've been in role. I want to bring you out of that role. Can I make some observations first? This is a simulation of the health system. And what we find when we run this is that, you know that phrase, art imitates life and life imitates art? So we construct the health system in a class environment like this, in a room environment, and it's eerily like the system out there. And that's what we discovered as we went through. At 10 minutes, the Federal Minister's Office and the Department of Health went to see the state governments, the GPs, and the allied health professionals. They probably went to see some other people too, but they didn't go and see the patients. Not for a while, they didn't. Oh, the usual federal government, oh, we did do that. At 20 minutes, there was a gentle nudge to remind people to go into role, because some people hadn't quite crossed the chasm to get into role of where they were coming from. At 30 minutes, there was lots of movements around the room and people were now interacting. But you know, it's interesting that we often set up the constraints that we then own and that constrain us. We set up the structures. We've set up a structure here of 10 groups. It's very hard sometimes to go and see another group. The media, table 6, we put you deliberately in the middle, not because you're the best and brightest of us, but we wanted you to be the focal attention. And we wanted you to have a focal attention of the rest of Australia. We're going to come to how you did your work shortly, but by not very much of elapsed time, you're off doing investigatory reporting. And I think you were starting to write tomorrow's headlines, even in the absence of knowing much of anything really. There was lots of interaction at 35 minutes and people were visiting each other and they were less constrained. And then the governments got together, which made me nervous. So what we'd like to hear is from each group. We'd like to hear what your perspective is. What standpoint did you proceed from as you did your work? Who should we start with? Should we start with the patients? What a novel idea. So what have we experienced? We're going to make a video of this. Thank you, Marcus. We're capturing all these views and trying to synthesize this down. But you've all just heard it. There's no magic solutions, is there? You knew that before you came. There are no magic solutions. And the health system is extremely complex. It's always about collaboration, negotiation, doing things together. And yet we often see the health system not doing that very well, collaborating across the boundaries and silos. And that really is quite challenging for all of us. I think there were some marvelous solutions and perspectives here. It's always the same. We are trying to reach solutions to complex problems without sufficient data. No one, for example, said, how much is this going to cost? Even the federal government saying, oh, I calculated they were going to spend maybe $5 billion. But they didn't say where the savings were going to come from. The doctors seemed to want more money for the care they were providing. And yet that would have to come from somewhere. So there aren't any solutions other than us collaborating together effectively to try and provide a better care system across time. That is the solution. We are the solution. But we don't often feel that way, do we? We often feel like, I'm just trying to navigate all this difficulty. So this is a nice, we'll give you a copy of these slides. This is a nice statement from our colleague Trish Greenhalgh at Oxford, who we work with a lot. And she said, you know, the articulations, workarounds and muddling through that keep the show on the road are not footnotes in the story. It's the central plot. The central plot is navigating all this complexity. Just a couple of things. Lots of stuff happened today. It was very interesting. I hope you found it as interesting as we did. We've put this on a number of times. This was probably the best we've experienced. It was really very, very interesting to get your perspective and hear all the nuances of the complex system that we're trying to improve. It's almost like we're flying a DC-9, a 1940s aircraft, trying to create an A380 while we're in the air. It's almost like that, isn't it? That metaphor of trying to create a better plane while we're flying it. It's almost like that. So there's lots of characteristics of the complex adaptive system that we saw today and you saw. There's a few lessons classically. One is there's no definitive solution in this time frame. We didn't walk away from this saying, we now know the solution to this complex problem. But there are many ways we can make improvements, and you captured most of them. The second one is, in a complex adaptive system, people pull and push in different directions. The Commonwealth, the researchers, the GPs, the nurses, the patients. Everyone wants a different version of the same thing, a better health system, but they want it from their perspective. Another lesson is parts of the system interact and affect each other continuously. This is a dialogue across time. It never ends. There isn't a destination. There's only a journey. And you know that if you're in rare diseases, because that's another metaphor for trying to find the diagnosis and deal with rare disease cases. Another lesson is people feel overwhelmed by the complexity. At times we all do, and yet we can't wish it away. The system's complex and we've got to navigate it as we find it. There's no simple solutions. All the simple solutions have already been adopted. What we're left over with in the health system is all the stuff that's hard to get to, hard to solve. And then finally, we may not be able to change a complex system easily or readily, but the question we're each faced with is how can we do our bit to nudge, influence and shape it over time? Because this is a long game. We're playing a long game in rare diseases. We're playing a long game when we're trying to improve the health system. So that's our conclusions to what you have experienced today. We hope you found it as fruitful and interesting as we did. What will happen is you will consolidate this over the next few days and weeks. It'll make more sense to you, maybe even in the next week or so when you reflect back on what you experienced. And in the meantime, we've got a video and some slides to deliver back to you. So thank you very much for participating. Congratulations to you. And Yvonne and Christina will conclude.
I really want to thank you deeply from the bottom of my heart. This was one of the best workshops I've ever attended, and it's been absolutely amazing having your input. And there's big thanks to go to everybody who came, but also to Jeffrey Braithwaite for doing an amazing job in facilitating, to Christina for organising it all, Nehal and Kaylin and Shalini for helping out on the day, Emma and everyone in the RArEST Project, Nat for doing all the note-taking and observing. Thank you so much, and we'll see you next time. Thanks.